Welcome back to Save Your Thyroid with Jennifer Holcomb, the podcast where we challenge the idea that thyroid surgery is your only treatment option. If you've been diagnosed with thyroid nodules, chances are you've been told that surgery is your next step. But many patients today want to avoid surgery because they don't want to spend the rest of their lives on thyroid medication. And many of us know someone who struggled for years to get their thyroid levels optimized after their thyroid was removed. But what if there were another way? What if symptomatic, benign thyroid nodules could safely be shrunk without surgery and without needing a lifelong prescription? In this episode, we're speaking with Dr. Britni Caplin, a board-certified ENT surgeon based in Murfreesboro, Tennessee, who's changing the way thyroid care is delivered. She offers innovative, minimally invasive options that preserve the thyroid gland, approaches that many patients don't know about yet. Dr. Caplin also holds a rare surgical designation that highlights her expertise in complex thyroid and parathyroid care, bringing a uniquely patient-centered perspective to the field. In today's episode, we'll cover topics like how thyroid care differs when managed by an ENT, why patients are seeking alternatives to thyroid surgery, and why she added RFA to her treatment options, and RFA versus thyroid surgery, how she helps patients to choose. If you've been told surgery is your only option, this conversation may open a door you never knew existed. Let's dive in. Dr. Caplin, thanks for coming on the podcast.
Thanks for having me. I appreciate it.
So you're a board-certified otolaryngologist, which is just a big word for ENT surgeon in Murfreesboro, Tennessee.
Right.
And you specialize in comprehensive thyroid care, including RFA. Tell us a little bit about what exactly that means in terms of treating thyroid patients.
Sure. So I am, what we consider a comprehensive otolaryngologist. So, did 5 years of surgical training at Vanderbilt. And after graduation, I went out into practice. So I chose, not to do a subspecialty or fellowship training after completion of my residency program. There were a lot of reasons for that choice, but ultimately it was because I really, had yet to kind of figure out which parts of otolaryngology were my favorites. Over time and stuff, I've developed this niche into thyroid and parathyroid care. Mainly, I think because I enjoy it. I find it challenging, and over time, that's evolved into learning about a lot of things that I didn't learn about in residency, and then being able to offer services such as RFA to patients to be able to really offer them as much as I can with regards to options for thyroid care.
Very cool. And you've got this special designation, the ACTPS Focused Practice Designation, which I want to talk about a little bit more in a minute.
Sure.
But also something really unique about you is you are a triathlete. Tell me a little bit about that for a moment.
Yeah. So it's just a hobby of mine. I have always been a physically active person, and in residency, I started triathlons just to really get back into shape. And you spend a lot of time in medical school and stuff studying and not as much time being active, at least for me. And so that was a way to challenge myself and get back into a sport, And so then, life happened and I had kids and all that. And so it was a goal of mine to get back into the sport. So this was my first season back into racing. And I do shorter triathlons, but they're a challenge nonetheless, and I enjoyed it. It just brings it a whole different level of, of satisfaction, and it's a great challenge, and I enjoy it very much.
Wow, that's awesome. I envy you very much there. Well, let's go back and talk more about your background. You mentioned that you were still kind of, when you graduated from medical school, you were still trying to kind of figure out what you enjoyed the most. So specifically, what drew you into thyroid and parathyroid care specifically that you enjoyed so much?
During residency, I always enjoyed, the head and neck surgical oncology rotation. That was something that I just really thrived in. It felt very natural to me. But part of why I enjoyed otolaryngology as a specialty was really the breadth of the procedures that we perform. There are things that take literally 2 minutes, like putting ear tubes in, all the way up to these really big head and neck surgical cases that are, several hours long. And so that was part of what I really enjoyed about the specialty. And then over time, as I graduated residency, I wasn't ready to give up any of those parts, and I had a mentor once tell me that, unless you really want to do one thing to the exclusion of everything else, practicing comprehensive ENT is good and okay. And so that's the path I went. And then, naturally over time, you just find yourself kind of going down these paths of things that you are interested in and things that you're good at, right? We like to do things that we're good at. And so For me, I walked into a situation here in my current practice where there was actually a general surgeon who was really a pillar of the community, who was near the end of his practice, and he did a lot of the thyroid and parathyroid care. And so it worked out well for me to come into this group with that being an interest of mine. And we worked together a lot during the couple of years of overlap that we had until he retired. And then it's just allowed me to continue to grow, that practice. And it's become the majority of what I do now, which I still practice comprehensive ENT. I still do those ear tubes on the kids and take out consults and do some sinus surgery and all that stuff. But, thyroid and parathyroid care is where I spend a lot of my time.
It's always one of my favorite questions to ask surgeons, this next question that I'm going to ask you, which is, what led you as a surgeon to want to pursue offering a non-surgical procedure like RFA?
Yeah. I think, there is this perception that surgeons, when given the opportunity, will use their surgical skill, you go to the operating room. And
Yeah.
I think that I've just learned. I mean, I love to operate, don't get me wrong, and I tell patients that all the time. Like, I love to go to the OR, I love to take out thyroid, but only when it's the right choice, for the patient. And so I've learned over time that, offering these non-surgical treatments, which require the same amount of skill, just in a different way. So it's just applying the same, just a different skill set, essentially, procedural skill set, which is still challenging, rewarding, and it's just, can provide the same benefits for the patient. So that's where over time I've learned to just listen to patients, like what they want, and how can we achieve that in a safe way, in an effective way. And I think offering these minimally invasive, like non-surgical approaches are just part of it.
And what are you seeing in terms of patients' satisfaction after RFA versus surgery?
I think thankfully, like, my surgical outcomes have always been good, and in general, my patients are satisfied after they have surgery. With the RFA patient population, as you know, it's a different population that will
Right.
come to you, seeking out this service, and they've been satisfied as well, and I always give patients the choices. I tell patients you're kind of sitting at this fork in the road, and there's typically at least two or three paths that you can walk down, and I'll give you the paths. I'll tell you which one or, two I think are best for you. And then you can choose. And so thankfully we've had patients, in both choices that have been really satisfying and satisfied. And I think it's really about patient selection for both and helping them to understand expectations and outcomes and what to expect out.
So then let's get into your eight, I want to say this right, eight ACTPS designation.
Yes.
You were in
Yes.
one of the first groups to achieve this designation. What is that, and how does that benefit you as a surgeon?
Yeah, so this is a focused practice designation, which it's a mouthful, but it's an adult complex thyroid and parathyroid surgery. So this was a joint venture between the American Board of Surgery and then the American Board of Otolaryngology to essentially try to identify surgeons who spend a significant portion of their practice offering treatment of more complex thyroid and parathyroid disease.
Oh,
And
okay.
so yeah. So basically, this was the first year. So we just all took the test over the same 3 days in April, and we all just got our result, found out if we passed the test. And so I have
Wow.
yet, yeah, we don't even know, like, I don't even know which other surgeons, have went through the process. So this was the first year. It's a brand new thing. So, but the goal really is to provide a list, almost like information for patients to know, is my surgeon someone who does high volumes of these types of cases? We know that in the United States, a significant portion of thyroid surgery is done by surgeons who do just a few cases a year. And
Mhm.
I think plenty of those surgeons are excellent at what they do, and they're fine with doing that. But we know that some of the more complex cases, like revision cases and things like that, some of these cancer cases are probably best done in higher volume centers. And so this
Mhm.
allows patients to identify which surgeons are doing that. So there were a couple different pathways in which you could, obtain this designation. For me, because I'm been out in practice now for 9 years. I sent in case logs, 3 years worth of cases, and you had to do a certain percentage of these cases that were considered complex, and then take the exam. So, and then moving forward, there will be ongoing certification exams and things like that to maintain that designation.
So I think this is incredible. I didn't know this existed until you brought it up in our conversations prior to the recording today. But it's something I've been saying for a while now to patients is that if you're going to have thyroid surgery, because some patients genuinely need thyroid surgery, you should go to a thyroid surgeon who is high volume. And the best outcomes are going to come from those surgeons. So it's really neat that you have that designation and that that's going to becoming more obvious to patients who are those high volume surgeons. So thank you for explaining that. I'd like to take a moment to thank the sponsor of this episode, Cambridge Interventional. Cambridge Interventional, a US-based company, has decades of experience in development, manufacturing, and sales of RFA and other medical devices. Radiofrequency ablation is a non-surgical, minimally invasive thermal ablation procedure used to treat various tumors, including thyroid nodules. If you have watched this channel before, you know that I personally underwent thyroid RFA treatment for a very large thyroid nodule and was able to save my thyroid and avoid surgery. If you'd like to learn more about Cambridge Interventional, please visit their website, cambridgeinterventional.com. A big thanks goes out to Cambridge Interventional for helping physicians to save thyroids and also for supporting this channel by sponsoring this episode. Now, back to the podcast. And talk with me about training in surgery and office-based interventions, because as an ENT, you do a fair number of biopsies in your office, right?
I do. In office procedures started for me very early on. So, it started with learning how to do ultrasound guided FNA. And, I remember doing those, early on in my practice, and it took a lot longer and that sort of thing. But things grow from there. Like in ENT, you do procedures in the office, whether it's like, scoping patients, doing ear tubes on adults, things like that, biopsies and stuff. So it's a natural part of like what we do, but evolving that with regards to thyroid care and stuff takes time. So it started with learning how to do ultrasound guided FNA, which takes time to get good at that. And then, also simultaneously, I was growing this in office sinus practice. So there's a big push in our field to be able to do sinus procedures in the office. So it takes, a lot of trial and error to learn about, good sedation and anesthetic techniques for those procedures. And all of that kind of applies to thyroid RFA as well. So then really for me, starting radiofrequency ablation was very natural. It felt, of course there's some learning curve to learning how to use a new piece of equipment and doing a new procedure. But a lot of the protocols that we use for anesthesia and sedation and all that were already in place, for other procedures. And so it allowed us to have a very smooth transition, into offering patients.
Let's talk about the differences between ENT and endocrinology perspectives here as you're managing thyroid care. So, what's your perspective when it comes to managing thyroid patients as an ENT surgeon?
I always will have a conversation with patients about this exact thing. I am so lucky that I have a wonderful team of endocrinologists that I work with here at MMC, or Murfreesboro Medical Clinic. We have two endocrinologists and they have several APPs that work with them, and I am in communication with them every single day. Like literally before I started this, answering messages back and forth about patients, and they're just down the hall. We often will work together. We have a very good patient, a flow for patients to be able to see both of us.
Mhm.
And, I always tell patients I'm like the structural thyroid expert, and they are the functional thyroid expert. And we work together, in those regards. And clearly those two things go hand in hand. And so, it requires the team of us to be able to give the patient the best care. And so I just see myself literally as one prong or one leg, that holds up that table for patients. And again, like I'm very blessed here to have the team of endocrinologists and then their AP.
Wow, that's so important that you can have that together in one facility where you can collaborate like that, because that's one of the most common frustrations patients have is how do I choose which type of physician to see when they're first kind of starting out their journey and they don't know, should I go see the surgeon? Should I go see the endocrinologist? And especially patients who don't really have obvious issues with their hormonal landscape of their thyroid. They just have a nodule that's kind of noticeable and they're having symptoms from it, but they're not hypothyroid, they're not hyperthyroid. But yet there are a lot of patients who are like, well, but if I go see the surgeon, they're going to just want to take it out. So I think it's really
Yeah.
nice to have that collaboration there and all of it under one roof. Even that's even better.
There's certainly overlap in like what we do,
Yeah.
because of that. And here, I think patients can't go wrong, like starting with one or the other, because if they need the endocrinologist, we'll get them in to see them. And, I was also going to mention earlier when you were talking about FNAs that we do this. We have now an FNA clinic. So,
Wow.
so the endocrinologist will refer patients to me for just FNA only. So once or twice a month, we have a block of a few hours where I'm just like bouncing back and forth doing FNAs for them, and
Hmm.
the patients go back to the endocrinologist. And then if they need something more, or we get a cancer diagnosis or whatever, they come back. So there's a lot of crossover here.
Wow.
So it makes it easy.
Yeah, that whole idea of a patient not having to bounce around from multiple sites in town to see different physicians, that's really going to lower their anxiety level and also the timeline that it's going to take for them to get from diagnosis to treatment to, them finally being done with this situation that they're, possibly seeing the doctor for. So you're in this practice where you're collaborating with endocrinologists, you're integrating surgery, FNAs, ethanol ablation, and RFA under one roof. Let's talk
Mhm.
briefly about ethanol ablation, who that's for, and when you would do that for a patient.
Sure. Ethanol ablation I use primarily for cystic nodules or then combination nodules. So if a patient has a purely cystic nodule, we can aspirate that nodule, but we know there's a high likelihood that that fluid will recollect.
Exactly.
Cystic nodules, some patients will present with this acute thyroid cyst that's uncomfortable. Why that happens, we don't always understand.
Yeah.
Draining it can give them some temporary relief, but we know it's likely to come back. And so those are the patients that are ideal candidates for ethanol ablation. And it works great. It works really well. We do use a combination of ethanol ablation and radiofrequency ablation in some patients who have mixed nodules. And so typically how I do that is I do the ethanol ablation portion first and then follow up with the radiofrequency ablation, just sequentially on the same day. But I think it's a great tool. It's very simple and, doesn't require a lot with regards to supplies and things like that. So I think it works great. I really like to use it to augment, radiofrequency ablation. And then for those patients who have just purely a thyroid cyst.
And surprisingly, even though it's been around for much longer than RFA in the United States, it seems to be harder to find physicians who do it these days. We actually have a number of patients constantly asking, I just want someone who'll aspirate my cyst and do an ethanol ablation because I don't have a solid nodule and I don't need RFA. So I'm glad to know that you're doing that. And so now let's talk about RFA, part that the really important part for today's
Yeah.
conversation. So you already mentioned about cystic nodules with ethanol ablation. So talk about the type of patients that you treat with RFA.
Sure. So, really starting with the basics when we started this RFA practice. So, starting with large, benign, symptomatic nodules. So, the patients that come in with a visible nodule or a nodule that's causing dysphagia or discomfort or compression in the neck, those solid nodules are the best candidates. I think starting out, it's great to pick the nodules that are, 3 centimeters, like, not the really big ones, just because of the learning curve, associated with the procedure itself. I like to have 2 biopsies on benign, non-functioning nodules just to assure, that benign pathology. But those were the first ones that we did. And then branching out, now I've done much larger nodules than that, and there are some caveats to that, which we discussed with the patients beforehand. Historically, it was like nodules above 4 centimeters. We recommended surgery for those nodules. And I think there's data now, maybe wasn't even convincing before that you needed to do that, and so now it's just allowing patients again to have choice, knowing what some of the risks are of both scenarios. And so those bigger benign nodules still do those. And then I've moved some into doing autonomously functioning nodules or toxic nodules. And those I think are very good patients for radiofrequency ablation. Again, if they understand the risks of doing that, and the potential for recurrence and things like that. I hope over time, I think radiofrequency ablation is such a great tool. Like once you start using it, you start to think about like all these other possibilities of
Yeah.
what you could use it for. And so for me, it's like, I think over time, man, it would be great to use radiofrequency ablation for, you know, thyroid cancer recurrences in patients who are not good surgical candidates, or
Yeah.
even in parathyroid disease, when patients are not
Hmm.
good surgical candidates. I think that, I've even thought about why don't we use radiofrequency ablation on parotid nodules, like things like that, parotid tumors. So I just think that there's a lot of, potential other applications, but just even with regards to thyroid and parathyroid disease. And I know there are a lot of people out there doing that, and I hope that over time, as this continues to evolve, I mean, things are just so brand new here in the US, right, with regards
Right.
to getting the code and insurance coverage for this procedure and that sort of thing. But as that continues to evolve, it's like, okay, hopefully we'll be able to see, more applications for the technology that allows us to reduce the risk of surgery in a reoperative case or things like that and treat it.
I agree 100%. And I am excited every time I see new data about another way that we could push the boundaries using this technology. You mentioned insurance. How is that looking today, given that we have a code now as of beginning of this year, 2025, but still there's a bit of I would say maybe growing pains with that because we're still not seeing 100% of the time it's being covered. So what's been your experience in your practice?
It's, I think it's been a tricky thing to navigate. First, I think surgeons
Yeah.
in general, like, we're not good about talking about money, right? When it comes to patients and things like that. I don't like to do that. I like to talk about, about the healthcare and not about the finance part.
Yeah.
But unfortunately, it's like we've had to do that. Like, we've had to get comfortable with discussing that with patients, both me as the provider, but then also my team. And so what we do is try to provide the patient as much information as we currently have. And it's basically evolving with every case, right?
Right.
So with every case, we're like, okay, we had a positive coverage here with this payer and didn't with this one. And so
Mhm.
we just try to provide all that information to the patients ahead of time so that they understand like what their obligation could be, if there is no coverage. And so I think over time, as the year goes on and as we head into 2026, I think that will continue to evolve. I also think that what we're going to see from insurance companies will continue to evolve with
Absolutely.
regards to, their requirements to meet the medical criteria to have the procedure. And so I think it's just in its very early stages, and it's just going to be one of those things that we all just have to be prepared for it to change all the time because I think it will.
100% agree there too. And as patients come in and they're asking about this, I know that's probably one of the first things they want to know is this amazing sounding procedure that I am interested in going to be something I can afford? That's definitely a tough conversation. I get questions about it all the time from patients in the community. And unfortunately, we have had to actually kind of shut down that aspect of conversations in the community because we don't see the trends, given that everyone's insurance is different all over the country. It's different. And so it just kind of stifles the conversation in the community as far as the scientific data is concerned. So that I always tell patients that's a question between you, your doctor, and your insurance company. So if
Exactly.
you're viewing this podcast and you have questions about that, I'm sorry we can't answer those in the community. Have that conversation with your doctor. Don't be afraid to have that conversation. Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation. As the patients are asking you about that aspect and then what the procedure itself is like, how do you explain that process to the patient of how the procedure works and what they can expect?
Sure. So most of these patients have had ultrasound guided FNA with me, and so they have that first kind of tip of the iceberg experience of what RFA is like. So I explain it using that as a base, we do our best to make our patients comfortable. We play music and have all the things to make people feel relaxed. And we spend a lot of time, with anesthesia and sedation and all of that. So I just explain that to patients that it takes oftentimes longer for me to get you ready to do this procedure than it does to do the procedure itself. And we do that to make sure that you're confident. And then typically, I will always go through the risks of the procedure, we know what those are, but, with any procedure, there's always the risk of, bleeding and things like that. There's risk of burn injury. We talk about the specific risk, with regards to, there are rare reports of significant bleeding, if a vessel is involved or things like that. Rare things like infection or delayed nodule rupture, or, risk of injury to that recurrence. And then I always discuss about the risk of recurrence and, ongoing nodule growth if not all the nodule is ablated, or if this is an autonomously functioning or toxic nodule, how it's important to put so much energy into that nodule. And if we can achieve that, it will reduce that risk of
Right.
ongoing hyperthyroidism. And some of these patients are complex because they come in potentially with one single hyperfunctioning nodule versus maybe a couple. And so having those conversations are helpful to patients. So I'm pretty thorough with those risks just to let them know, as I am with surgery as well. But
Right.
thankfully, as we know, the risk of injury to that recurrent laryngeal nerve in both surgery and RFA is low. Risk of hypothyroidism, very low, which is one of the big benefits for people here. I've learned in doing this that afterwards I tell patients, it feels worse at first. It looks worse
Right.
and it feels worse. As you treat that tissue, it kind of draws up. That's how I describe it. It gets tight, and sometimes they sit up and they're like, oh gosh, but we use the ice and all that. And it's like, it's 24 hours of tough, and then it typically gets better, and we always check on our patients the same afternoon to make sure that they're doing okay. And really patients within 24 hours are feeling pretty good. And then I was like, then we just have to wait, so
Yeah.
it takes time.
Exactly. I want to touch on two things you just said there. The 24 hours of tough, I think that's perfect. You nailed it there. That was my experience with both. I had two RFA procedures, and the first 24 hours was the toughest of after the first procedure because I had a really large nodule. So I
Mm-hmm.
had a lot of swelling and soreness for that first day after the first procedure. Actually, the first 24 hours after the second procedure was nothing in comparison, but it's all better after that. It's all uphill after that. And
Yeah.
or should I say downhill after that? Because it's going to take, as you said, it's going to take time for the nodule to shrink. It's not an instant reduction in size. And sometimes patients don't understand that. We try to make that clear. This isn't like you're going to leave the doctor's office with that instant gratification of a reduction. But I would say that the vast majority of patients find it worth the wait.
I
So,
think so too. Yeah.
and especially due to the safety and efficacy and long-term outcomes. What have you seen in terms of that in your own practice?
We've done well so far. So our protocol typically is that we treat people like on day zero. I see them back about 90 days later, 3 months or so, and I do an ultrasound in the office, and then again about 6 months. And so we've gotten patients. Or we've been doing this a little less than a year, so we're heading out. We've got some patients that are almost at that 1 year mark now. But really at 3 months, I mean, we've seen 60 to 75, percent volume reduction. So we've seen really good results, and I always encourage patients like this is only going to get better with time. But at that 3 month appointment, we always feel like it's a high five, for the patient.
Yeah.
They can see the difference and feel the difference at that point. And I tell them that, this is probably the most dramatic that you're going to feel. And then over time, it's just a slow and steady, reduction in that volume until we reach that year-ish mark, And so thankfully we've been lucky in that. I think I've done, as I learned to do this, I got lots of feedback from the manufacturer. We would review the data afterwards to see, okay, like, are we reaching the proper impedance, tissue impedance, all that stuff, the proper tissue temperature, how much energy am I putting in to this tissue? And before every patient, I do, volume calculations, remeasurements, volume calculations. I know what my goal energy level is for every patient going in, and I will reach that. I want to reach that energy level to make sure that we're ablating the nodule appropriately, depending on what type of nodule it is.
We haven't talked about that. Let's talk about that a bit about how, as you're introducing this probe into this thyroid nodule and it's delivering heat into the nodule, you're choosing a certain level of energy for these particular nodules based on what exactly?
Based on the volume,
Okay.
whether or not the nodule is autonomously functioning or not. We know, with the available literature that if you treat a nodule with like 2 kilojoules per square or per cubic milliliter per milliliter, I guess it is, that, you're less likely to have a recurrence and that it's hyperfunctioning nodules. And so I typically use that 2 kilojoules just for my gold standard, for patients. that I know what the volume is and I want to reach that 2 kilojoules. And I've learned over time, looking at my own ablation data, afterwards, the case data about how to do that and make sure, where you can achieve more energy, and watching those tissue impedances and the tissue temperatures and stuff. And the nice thing is you get that real time feedback as you're doing the
Yeah.
procedure, and you can watch the energy levels, you can watch the tissue temperature, all of those things to help you to know that as you move along that you're going to achieve what you want to achieve.
For the viewers who are watching this and aren't exactly sure what we're discussing here, the generator for the RFA device actually will tell you on the machine how much power you're delivering into that nodule. And you can watch this in real time as the procedure is being conducted. And I don't know exactly which iteration of the generator you have, because it's been a couple of years since I've seen the generator that you use. I think it's really interesting how much science goes into making this generator show what's happening with the power. It's not like you're just blindly sticking a probe in and hoping for the best. You're actually looking at all of these different things that are happening with regard of the power delivery, how much power, something called impedance, where there's like resistance against the power, and just all of these things are kind of way over our heads as lay people, but they're just for the people watching this who don't understand all of these things. And I don't fully understand all of these things myself, even though I've been immersed in this for 6 years now. I just think it's really interesting that we have so many things in place with regard to this kind of treatment to really ensure success. And the outcomes that you mentioned a moment ago with regard to reduction with the patients, those are excellent outcomes. Patients sometimes, when they're new to learning about this, they don't understand that the nodule is probably not going to completely disappear. It's going to shrink, it's going to reduce your symptoms, and that's the ultimate goal, not disappearance. And so a 60 to 70% or greater reduction, that's an excellent reduction, especially for those patients who have really large nodules, whose nodules are really causing a lot of symptoms where, they can feel it when they swallow, it causes them to cough, or you can even see it in their neck. That amount of reduction, even though it's not, 100% gone, that's enough to cause a significant improvement in their symptoms and their quality of life. So I just thought that was worth mentioning. So now let's get into how you actually help these patients choose a procedure, whether it be RFA, ethanol. We kind of talked a little bit about ethanol. We'll talk about that one next. But first, let's talk about just RFA versus surgery. How do you help a patient choose between those two options?
Sure. I think it's very patient dependent. And I mentioned briefly about, telling patients that there are typically at least 2 to 3 choices. So when a patient comes in, say, for example, they have a 4 centimeter solid nodule that they feel, they can see it, they can feel it when they swallow, or they have some compression symptoms from that. I tell patients, and they've had one benign FNA, I tell them, you have really 3 approaches that you can take here to do nothing. And that's okay too. If you have a benign FNA, we can watch this nodule and get another ultrasound in a year. And if it changes, we'll reconvene and readdress it. And so that's like the most conservative thing. And the most aggressive thing would be maybe to consider surgery, whether it's a lobectomy or whatnot, depending on the patient. And then, the middle of the road option is this and, radiofrequency ablation. And I go through with them really the risks and benefits and how they relate to each other. And I think that helps them. I try to get some sense of what's important to them, because for some patients, it really is about the medicine. They do not want to take the medicine. Or for some patients, it's the fear of surgery. Or for some patients, like they don't want to lose a part of themselves. Like they feel, and for some patients, it's about recovery time, so there are really different reasons that people will choose one path versus the other. Whereas some patients who choose surgery choose that because they don't like the thought of having this nodule that could, harbor something or that they have to continue to follow. And so I think with patients, it really just depends on what's important to them, what their life circumstances are like, and just helping to guide them by providing them the choice. And usually I can tell, when I'm talking to someone, what they want. Or a lot of times we send patients home to think, I'll tell them like, you don't have to decide anything. Like go home and think. I have a nurse, Jen, who you've spoken with before, and she she does a lot of phone calls. So she follows up with patients and has answers additional questions for them to help them to make a choice. So that's typically how we do it.
I think that's so great that you don't have that perspective of you've got to choose right now. And I think that's fantastic that you do that because so many patients come in our community and they say, "Oh, well, I was diagnosed and they scheduled me for surgery on the same day." And unless you have some kind of nodule that's really concerning, that's like kind of an emergency situation, I tell patients you most likely don't have to make a decision on this right now. You have time to think it over, to weigh out the pros and cons. Like you said, consider your lifestyle, what you need in terms of recovery time, what's important to you, what do you value the most in terms of after this procedure, how are you going to feel about being on medication versus having a scar versus
Mhm.
having the follow-ups. And I always tell patients too, you're going to have follow-ups kind of regardless of which path you
Right.
choose, right? Because you're always going to need to make sure that whatever has been done is maintaining whatever the outcome that you anticipated was. So I think that's fantastic.
We try to be as efficient as possible for those patients who know what they want. And so
Yeah,
we
yeah.
We definitely pride ourselves in that we try those patients that are ready to move forward, we try to schedule and try to make accommodations for them. And patients, I think we'll probably talk about this a little bit later, but patients who contact us who are interested in radiofrequency ablation, we really try to minimize the number of appointments, for
Yeah.
those patients that are ready to move forward. But certainly from our standpoint, I tell patients, you have to be 100% sure that this is the right thing for you, whatever you choose. And it's hard to do that with any big decision like that, but I find that patients do better regardless of what they choose if they feel confident in the choice. So I just wait for them to feel that.
I think that's great. And I think that patients will appreciate that. I'm sure that they do in your practice. Now let's kind of jump into ethanol ablation. We talked about it a little already, but some patients maybe will just need ethanol ablation versus they might need a combination of RFA and ethanol ablation. So can you get a little bit more detailed as to how you choose which one in that situation?
Sure. So if I think a patient may do well enough with the volume reduction, again, we talk about like the symptoms are associated with the volume, right? So that's the goal here is to reduce the volume. And so ethanol ablation is so quick and so easy, very similar to just a needle biopsy. So if we're unsure about that, I'm like, let's do the ethanol ablation part today while you're here. If you want to do that, that's easy. It's just like the biopsy that you've already had. And so we could do that and we can see what you get, from that. And then, so if we're unsure one way or the other, taking it in a staged approach like that is fine. And something that we do, or, if we feel like we really need that combination approach, then we'll plan to do it all sequentially on the same day.
Have you ever had a patient that needed multiple ethanol or RFA ablations?
So far with ethanol ablation, I have had patients that have had more than one cyst that needs to be ablated. With RFA, I think partially because I'm younger in this practice, earlier in this practice, that I have not yet had a patient who needs an additional treatment, but I know that time will come. If you do this long enough,
Yeah.
whether it's the same nodule that needs a second treatment or another nodule that needs treatment. So it's one of those things that it will happen. It just is a matter of when.
Yeah, yeah. Those bigger nodules, probably the ones that you're still not getting towards just yet in your practice. Those are the ones that oftentimes need a staged approach. And I'll just touch on this briefly because this was my experience. I had a nodule that was quite big. It was between 65 and 75 mLs. It's kind of hard to determine exactly how large it was because it was so large. At that time, it was actually going off the edges of the ultrasound screen.
Yeah, yeah,
Um,
yeah.
and part of it was below the clavicle, which,
Hmm.
for those people watching this who've not dove into this area yet, ultrasound guided procedures can only see above the clavicle. They can't see through the bone. And so when you're ablating, you have to be able to see what you're ablating in the RFA procedure. So with mine, it was 80% of it was above the clavicle. We treated that in the first round. Then after a few months, it started to move up as it shrank.
Hmm.
So that lowest portion, as it moved upward, became visible. It was no longer hidden by the clavicle. And so about, I think, 8 or 9 months later, I went back and had the rest of it treated in my second RFA procedure. And I've had a 90% reduction that I've
Amazing.
maintained for 6 years. So I couldn't be more thrilled with the outcome. And we have so many patients who have similar experiences. So do you want to share any patient stories, and you can keep these anonymous, of
Sure.
outcomes that you've seen in your practice?
I think, in general, our experience has been that patients are excited and they're happy when they come in. And I've had one patient that was a similar story to yours, that we were treating this very large isthmus nodule.
Mhm.
And she got great volume reduction from that. But what happened as that nodule shrunk is it pulled this tissue up that we didn't know was there, because it
Mhm.
wasn't captured on ultrasound. So she had a substernal nodule that we weren't aware of that we can see now on
Yeah.
ultrasound. I'm like, well, now we know it's there, and we biopsied it's benign, and we're watching that. So, and she had never been scanned, so we didn't know that tissue was there before.
Mhm.
And so, but I have patients who are very active who've had the procedure done to avoid the downtime from surgery, and other than that, first 24 hours have done really well and have been happy with the results. A lot of people who just really describe that slow kind of change in volume, and they all of a sudden they'll just look back one day and be like, I don't feel it. I haven't felt it,
Yeah.
for a while. And so that's the general consensus, for my patients so far. So we've been grateful to have good outcomes for sure.
Excellent. Well, we've talked a little bit about how your practice supports this integrated care and you're working alongside other specialists all in one system. How does the patient navigation or coordination work there? You touched on that a moment ago. So the patient comes in and then they have access to all the different specialists under one roof. Can you kind of expand on that a little bit?
Sure. So it depends on how the patient enters our care. If a patient comes through a primary care doctor, which is also under the umbrella, then they will often, if they refer the patient to endocrine or to us, if the patient requires surgery, my patient coordinator, Sabrina, she reaches out to endocrine and she coordinates follow up with them. We mentioned the FNA clinic for patients that need those biopsies. And so it's really there's a lot of communication. We do try to do a lot of same day appointments for patients, meaning that they can see both specialties on the same day when follow up is required. Yeah, exactly. And so that's helpful. We talk to each other every day. Here also in our practice we have radiology, so we're lucky to be able to have. I do a lot of my own in-office ultrasound, but certainly, I have plenty of patients that get radiology. They can get CT imaging if it's required there. After if for post-surgical care, if patients need um, radioactive iodine, our endocrinologist can do that. So we really are lucky. And then our surgery center also is under the same roof, and so it's nice to be able to do everything. We have lab and everything. So patients it allows us to do more of that one stop, you know, um,
Yeah, that's fantastic.
for patients to be able to get everything that they need in as few visits as possible. And our departments do a great job coordinating with each other to achieve that.
Yeah, I was right before we actually got on the call today, I was looking at the website for your practice, and it's a huge practice with
Hmm.
all kinds of different specialists all located within one giant umbrella. And I think
Hmm.
that's really interesting. I don't know of a lot of practices like that. I'm sure they exist, but like just seeing that you have so many different specialists, even like you mentioned, general practitioners that can refer within the same practice. That is really, really helpful to keep the patient's appointments, as you said, to a minimum, avoid them having to go all over town and spend so much more time. Patients complain, I want to see an endocrinologist, but the wait list is 6 months to a year. Perhaps they come to your clinic and maybe it takes a little longer to see one specialist, but they can come see you. And so that can kind of coordinate their care accordingly. What is one thing you really want patients to know about their options for thyroid care as we're kind of closing this out?
Or, I just want patients to know that they have a choice, certainly, and that it's our job as your physician or your healthcare provider to give you the options and to help you to navigate those choices in the context of your own life and your own desires, your own goals, and so that the treatment options are out there. And sometimes you do have to work through finding someone, who is willing to provide those choices or to listen, and that's the one thing I've learned over time is that if you listen, you can really make a big difference for people in understanding what they need, and then how our job is to really identify how we can achieve that for them in a way that's safe and efficacious, and so that's really the main thing. And I think being in a place where we can really offer, truly comprehensive thyroid and parathyroid care is such a blessing, for me and for our patients.
Yeah.
And so I'm thankful for that.
Awesome. Well, patients watching this, if you want to reach out to Dr. Caplin, you can visit their website at mmclinic.com. You can learn more about RFA at mmclinic.com/RFA. You can also follow them on Instagram at Murfreesboro Medical Clinic.
On our website, if you go to the mmclinic.com /RFA, there is a link that you can click that says, it may say to request an appointment, but you can put your information in. And if you put in there about RFA, which is what that page is for, that request will then go to my nurse, Jen, who will call you, and she will get your history, help you to send, to obtain the records, the necessary records for us to review those, and to see what you would need potentially prior to considering RFA, or if I felt like you were a good candidate for RFA. And then if you do need additional testing or biopsies, we try to achieve that, in one day at a visit when you come to see us for a consultation in the office. So there are ways to find out if you're a candidate, or have me review your records ahead of time if you're curious, by going to the website and clicking that link and submitting.
That is wonderful. Wow. Yeah, patients all the time are asking us, how do I get this? How do I get evaluated to find out if I am even a candidate for RFA? And I always tell them, the best thing to do is to see someone who actually does RFA. And so even if you aren't in the Murfreesboro area, if you're somewhere surrounding Middle Tennessee and you're looking for a physician who can do these kind of diagnostic evaluations, this is where you can start that process on the website. So patients watching this, if you want to explore non-surgical options like ethanol ablation, RFA, or if you just need an ENT surgeon, reach out to Dr. Caplin in the Murfreesboro area of Tennessee. Thanks, Dr. Caplin, for joining me today. This has been fantastic.
Sure. Thank you so much for having me. I really appreciate it.
That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.